that focuses on we're going to start over. All right, welcome everyone to this week's Power Peptide Talk, which is a weekly Zoom call that focuses on all things peptides and finding ways to thrive as we age. So for those of you that don't know me, I'm not Blair Critch. I am Joey Udovich, and I will be your host tonight. So my journey with peptides started in the summer of 2024 when I was in the midst of being put into surgical menopause after a double mastectomy and complete hysterectomy. It was a rough time in my life. Peptides have literally changed my life. I started with only knowing about GLP-1s, and since then I have completely learned and enjoyed about so many other peptides. They are life-changing, and it is such a joy to talk to people about them every single day. Hey, Blair, can we mute everybody? I'm going to unmute myself. Okay, thank you. So these peptides are changing people's lives, and it is truly my honor and pleasure to introduce someone to you tonight. It is the guru of peptides, Dr. Jason Pencek. Jason is a board-certified nurse practitioner and chiropractor specializing in both conventional and integrative medicine. And after starting as an RN in 2010, he earned his Doctor of Chiropractic degree, and completed his nurse practitioner training to expand his scope of care. With over 6 years of experience using peptides, Jason has advanced training in regenerative therapies, IV nutrient therapy, hormone optimization, and metabolic health. Nearly half his practice focuses on GLP-1 therapies for weight loss and disease prevention, and he currently serves as a panel moderator at the World Biohackers Congress in Chicago. Very impressive, contributing to the future of personalized functional medicine. So Dr. Pencek, welcome again. This is my second meeting with you, and I'm so glad that you're here tonight.
Thank you. I'm glad to be here, Joey.
So the last time he was here, we talked about GLP-1s, but tonight we're shifting because we have other things to talk about. So tonight's topic is going to be about, I think we're going to start with Tesamorlin, Ipamorlin, and then we're going to go into NAD Plus. So the Tesa-Ipa is a really, really hot topic right now, I'm finding. This is very cool. I hope everybody's here for this. We are going to dive into the education, and I'm going to kind of let him talk, but I'm going to start with, for those people that are unfamiliar with what the Tesamorlin, Ipamorlin is, what is it? How does it work? What does that look like for somebody? Why would anybody want to be on it?
Yeah. So Tesamorlin and Ipamorlin are two different products that can improve growth hormone output. So what we care about is growth hormone. Growth hormone goes down significantly after puberty. By the time you hit the age 30, you lost about 20 to 30% of it, and it goes down about 15% a decade after that. So by the time you're at 60, you're at 10 to 20% of the growth hormone you were making when you were in puberty. What does this mean? This means sleep isn't as good. We have more visceral fat, more fat in general. Brain function isn't as good. Muscle mass becomes a lot harder to put on. Skin quality goes down. Sexual function goes down. Immune system doesn't work as well. We see issues with people, telling me that I just feel like I'm getting older, which is a big thing we see with growth hormone. Growth hormone goes down, and it is this feeling you get that makes you feel like you're getting older. So basically, testosterone and ipamorelin are one of the best options combined to improve growth hormone output. And how this works is testosterone is a growth hormone releasing hormone, and ipamorelin is a growth hormone releasing peptide. Ipamorelin works on ghrelin. So ghrelin is the hunger hormone that we have. And the ipamorelin does work on this whole hunger aspect. And when you work on the ghrelin system, you have improvements in growth hormone output. When you put these two together, you have a giant synergistic pulse of growth hormone. And testosterone is the strongest. So I know LEMD already has sermorelin. It is a lot weaker than testosterone. Testosterone can raise your growth hormone, IGF-1 levels to about 100, 150, put in more than natural normal range. It is equivalent to taking 1 IU roughly of growth hormone. So if anyone out there is familiar with growth hormone, it's going to work similar to growth hormone. The reason we like the growth releasing hormone, growth releasing peptides better is that they create a pulse like your body naturally would do. You want to keep this as natural as possible. Growth hormone gets super physiologic, meaning you're having way more than you need, and also has something like insulin resistance going on. When you use tesamorlin and ipamorlin, you don't have insulin resistance, you actually help insulin sensitivity. So there's a benefit for using this over using growth hormone in general. So there are lots of reasons why we like tesamorlin and ipamorlin, but my favorite is you can use it long term. and we don't shut down the body's natural production of growth hormone. So I love Tesamorlin and Ipamorelin. The combo is such a great option to have. I'm so glad LMD brought it on. I've been using Tesamorlin in my own practice for many years. We see great results. When you pair this with something like a GLP-1, my God, the big thing everyone worries about when we're on a GLP-1 and we're on a weight loss journey is muscle loss. Everyone's so worried about losing muscle. And of course, we're always recommending, hey, eat more protein. You need to go do strength training. You need to get some exercise. And these things are being told by everyone out there that's working with the GLP-1. When you add testosterone and ipamorelin in, you're able to hold that muscle better while you're in a calorie deficit. So you go into a calorie deficit with a GLP-1, like semaglutide or tirzepatide, and all of a sudden you're able to keep that muscle mass while you just burn fat. And there is a fat burn portion of testosterone and ipamorelin. The reason testosterone and ipamorelin have gotten such traction is that there is no increase of cortisol. There is no increase of prolactin, two things we worry about. If anyone's familiar with cortisol, this is your stress hormone. When it goes up, that belly fat starts to go up. So we do not want an increase in cortisol. We don't want to increase the prolactin either. Having prolactinemia or high prolactin is very bad for us. So when we're looking at what testosterone and ipamorelin can actually do for the body, we start to see all these great benefits. Hey, I'm going to have a better immune system. I'm going to have my brain function start working better. I'm going to see a drop in visceral fat by up to 20%. Now, visceral fat is something we do need to focus on here. Visceral fat is the fat around your organs. This is a huge deal. When you bring down visceral fat, for example, around your pancreas, you're able to reduce type 2 diabetes. So now we can have a reversal of type 2 diabetes in patients using testosterone and ipamorelin, even if you're not doing a GLP-1. Fat of the around the heart also is going down. So we're seeing reduction of cardiovascular disease in patients. So there are tons of great longevity benefits from being on testosterone and ipamorelin. Again, the visceral fat is a big one. We also see adipose fat, just in general, more of a fat burn. So you have more fat burn by being on this. Again, I talked about skin improvements. People come back and say their skin is looking a little thicker, it's more full. You get to hold that skin better, a little smoother too. When you increase IGF-1 levels, typically you get smoother skin and more collagen production. Increasing collagen production, my God, every woman out there wants this, right? Every woman is looking for ways to increase collagen as we age. Collagen, unfortunately, is just going down as you age. That's just the simple fact for everyone out there. And I think we understand, especially in females, it's really hard to get over the fact we're getting wrinkles. And you start to see these come on and like, what can I do? What testosterone and ipamorelin can help reverse some of this? It can improve that collagen production, help reverse some of these fine lines and wrinkles that you're getting.
Can
Again,
I can I pause you?
yeah, go ahead. Sorry.
I always have to cut him off, you guys. This is, you know this, Dr. Pez. This is like your wheelhouse. So I've got to say time out. Okay. I just want to go back for a second because I have a couple of
Yeah,
questions. So
of course.
somebody said, can you share how visceral fat is measured? Isn't that through a DEXA scan? Isn't that the
Yes,
true?
correct,
Okay,
correct.
so DEXA scan. And you would just get that through your doctor.
Correct. There's some of the wellness clinics have it. You can go to your local, some gyms have DEXA scans. Yeah, you're not going to get a DEXA scan. The bioimpedance that people do, um, I guess the in-body, we have one in our office. It does measure visceral fat. So you can do an in-body. I always tell people tracking is better than nothing. I hate to brag here, but my visceral fat is less than one. So I have like no visceral fat, and that's gold. So I always
Sure,
tell
sure.
people, yeah, we can measure visceral fat with the body impedance. So in-body would work. Again, DEXA would be the number one gold standard. So if everyone wants the gold standard, a bit more expensive, hard to find, but these in-bodies that some gyms have, they also measure visceral fat. I typically tell patients with an in-body, I want a visceral fat 4 of less if possible. Bringing that down, again, longevity is huge from that.
Okay, great. So my next question is you talked about women, and I would like to focus on that just for a second because I'm somebody who surgical menopause, age of 41, stuff's happening faster than it should
Yeah.
be. So can we talk just for a second, because I know there's guys on this call too.
Uh-huh.
What are like the major benefits of taking Tessa IPA for people like myself?
Oh, I mean, the thing is, after we go through menopause and just in general, hormones in women and men go down. So we start to lose loss of testosterone, which is very common. And for a lot of women out there, they don't have a practitioner that will get them testosterone, even though I think it is super necessary to get testosterone in women. But if you're not able to get to that testosterone, you can still improve that muscle mass, which is huge, right? I know no woman out there wants to become a bodybuilder. We don't have bodybuilders on this call. They're not trying to get, jacked and be doing bodybuilding shows, but we do want to look toned. We don't do want to look fit. This is why we use GLP-1s. I think everyone on this call will agree. I don't care if I lose all my fat, if I lose all my muscle too, I'm going to be skinny fat. What's the point of being skinny fat?
Right.
We all want to have muscular toned bodies. Testosterone can really improve that tone because it's going to allow more of a fat burn while holding on to that muscle. So you're able to build more muscle mass while you're on this. Even if you're not on GLP, if you're not in a calorie deficit, you're able to build more muscle and get stronger. So there is a big benefit for improving your overall muscle quality. That's number one for women. I think muscle is the currency of aging, and women want muscle as much as men. They just don't want to look like they're, broad shoulders and like the typical really beefy women out there. Now, the second thing, again, we said is collagen production. This is a really big one for women. Collagen production is also huge. We see improvements in skin quality from being on a testosterone and ipamorelin blend. Again, what we like about it is they synergistically work together. What I would say here, 1 second before I step back, is that what we like is that growth hormone releasing hormone is akin to you stepping on the gas and pushing out more growth hormone. So that's what we're doing here, pushing the gas down with testosterone. Now we have something called somatostatin, which is hold on to the pituitary. It's on the pituitary, holding down how much growth hormone we actually make. So this is the brake. So when you push down the gas and you don't have to brake off, you might move forward some, but not very far. Now you have this ghrelin agonist, basically growth hormone releasing peptide, ipamorelin, actually pulls somatostatin off the pituitary and allows for the body's brake to come off. So now what happens when you take the brake off and the gas down? Now you have a car moving really good forward. So this is why they work synergistically together. If you take just the brake off, you might not get much movement, but some forward. So you put this together and you have this giant increase in growth hormone output. And in the first month, you have this giant increase. So it doesn't take some of the peptides, might take some, really might take a few months to see that full effect. With testosterone improvement, within 30 days, you have the full effect of growth hormone going up. So again, collagen production goes up. You're going to see improvements in muscle building. A big thing we see with women as they age, libido goes down, right? That's a very, very common thing. You go through menopause, you start to get in your 40s. What happens is that these women are, sitting here telling me, hey, this is part of the issue. My libido is not where I want it to be anymore. Well, that's partly growth hormone, also partly testosterone. So if I can add testosterone back in, now you're starting to bring some of that libido back to women as well. So these are all things that I'm hearing as women age, moving in the 30s, 40s, 50s, and up. And these things really do matter to women. I mean, again, the men are getting the same benefits as the women as well. But realistically, I see women getting such good results from testosterone and ipamorelin. I feel like when men are kind of it's on or off, either it works or it doesn't work. And women, you are very in tune with your bodies, much better than most men. So you can tell this little thing mattered, this little thing changed, this little thing's slightly better. So you see the benefits a little better than men do. Men will get on it and say, nah. When I first started using the testosterone and ipamorelin blend, this was 6 years ago. I was confused. This is brand new to me, just like everyone else here. And I was thinking, hey, this is weight loss. Come on in. Let's do weight loss. Because again, that's the one thing obviously women care about too. This is why the GLP-1s are so attractive. And I was giving it to every person as a weight loss option. Hey, it's going to burn your fat. You're going to lose all this weight. And I was sorely mistaken. When I started using it in patients, I didn't get to see that. People would come back and say, I lost a little bit around my waist, maybe I lost a couple inches, but they weren't seeing that extreme weight loss that we see with GLP-1s. Now they have GLP-1s added in. I'm like, oh my gosh, this is the place testosterone really shines. If you're already to the spot you want to be, or getting down and moving down, you're having something to bring you down to that weight you want, like a GLP-1, you pair that testosterone and ipamorelin, and now you see more fat loss and that muscle going up, which is why it is so attractive in general and why I use it so much in practice now myself. I personally take testosterone and ipamorelin. I'll cycle between that and IGF-1, LR3, but testosterone and ipamorelin is one of my favorites.
Somebody was asking about that. I saw a question. I want to go. It says concern with cancer if increasing
Oh,
IGF-1.
yeah. Good answer. This is double-edged sword with ipamorelin and testosterone. If you have cancer already, we do not recommend being on any growth hormone peptide or growth hormone releasing hormone or even NAD. So anything that's going to increase what's called mTOR, we do not want to do. Growth anabolic, not good when it comes to cancer, just terrible. Now, if you don't have cancer, testosterone and ipamorelin improves the immune system. So now surveillance of cancer cells goes up. We're finding this stuff and getting rid of it before it happens. So unfortunately, as everyone will probably ask, is there a test for this? There's a test called Gallery that's a blood spot test you can potentially get from your practitioner. It does do blood testing for cancer. It is not, again, the most accurate thing in the world. So there's no real good way to say, hey, I have cancer, hey, I don't. We can look at statistics. Most people, average age of cancer is about 66. So most people don't get it till they get much older. So usually your older, younger people don't really see cancer. Again, not that it's not growing or potentially there. But I do tell people if you don't have cancer actively, this is a really good option because, again, it will prevent cancer from potentially growing and occurring. So I always want to push this is a great space to be in because you're preventing it from happening if you don't have it. And if you do, unfortunately, it could potentially grow. So don't use it in that case.
Okay, great. Let's take one more question here on this, and then we can move on to NAD.
Okay.
And sorry, guys, because I know we could spend hours with him and asking him questions, but we're gonna have to cut you off. All right, let me see here. It says, "Do I stop Samorlin to then add in Tessa Ipa?" She says, "I love Samorlin and take it currently with semaglutide." I'm assuming you should not take both together, right?
You could, by all means, if you want to bring more money to the table and pay more, Sermorelin does not do anything when it's with Tesamorlin because it's so much more powerful. So if you want to keep spending money on the extra Sermorelin, by all means, go ahead. It's not going to hurt you. But is it going to be effective? Absolutely not. Testosterone is so much stronger. It's going to wipe out. They're both growth hormone releasing hormones, and you can only get so much into into the receptors. So it's going to pick the stronger of the two. The affinity is better for testosterone. Therefore, Sermorelin won't really work as well. So no, you could just drop the Sermorelin. There's Sermorelin, there's CJC 1295, and there's Testosterone. These are the three most common growth hormone releasing hormones that we see out there. And Testosterone wins over all three. So if you're going to do anything, it's going to be a growth hormone releasing hormone with a growth hormone releasing peptide. There are also several other growth hormone releasing peptides, such as GHRP2, GHRP6. We do not like those, and I'm glad LEMD is not using them because they increase hunger and prolactin and cortisol. So my first time injecting GHRP2 and 6, God, that was the first peptide I've injected. And it was Sermorelin, GHRP2, GHRP6. I could not find food fast enough. I did an injection, and within 5 minutes, I was starving. And I don't think anyone here is looking for a response of, I want to eat everything in sight. I mean, gummy bears, it didn't matter what it was. I'll eat everything when I'm on GHRP2 and 6. So I always tell people we don't like the other GHRPs. The best one is going to be Ipamorlin. It usually has the least hunger with it and also has the most improvement of getting up the growth hormone numbers when paired with testosterone is the strongest GHR.
Okay, wonderful. And listen, just before we move on to NAD plus, Dr. Pencek did a very, very thorough walkthrough with the tesamorelin, ipamorelin was it last week? What is today?
Right.
Today? Okay, yeah, it's Monday. So on Friday. So that is on LEMD's educational series, which you can find on YouTube. I always just go to YouTube and search LEMD, and then you can view the channel, go to videos, and it's going to be the most recent. So check that out because he really covered all the bases there. So I hate to rush through, but we're going to stick to a little bit of a time frame. All right, we're going to go into NAD Plus, which is not a bad topic to talk about.
No.
This is one of the best sellers on LAMD, which I think it is. I don't know. I don't know if the Kardashians, if they,
Bieber, I think the Bieber, what's the white girl's name? Hallie.
Haley.
She and the Kardashians got into it, and the
Yeah.
whole world is very well acquainted with NAD plus. We now everyone wants NAD levels raised, right? We want NMN, which is nicotinamide mononucleotide, which is a supplement. There's NR, nicotinamide riboside, which is another supplement. There's also NAD orally, which is technically a supplement, and then we get to the sub-Q, which is really where we shine. And then I know LAMD offers, which is the most talked about and the most watched videos that I have on Instagram is just NAD. And yes, it is quite amazing.
Yeah.
I recommend NAD to pretty much anyone. Again, same idea. If you have cancer, I'm not using NAD, but the same idea. If you don't have cancer, it improves the immune system and you'll get rid of, stop the cancer from growing. So again, same idea with NAD, but what is NAD, right? That's the big question. Um, Nicotinamide adenosine dinucleotide is a cofactor. It is the last cofactor needed in our mitochondria, one little powerhouse of the cell. This is what creates ATP and energy through oxidative phosphorylation and the electrotransport chain. And what happens is NAD is necessary to make more cell energy. So if you want to have more energy at a cell level, remember this is overall energy. Your whole body's going to function better. If you can bring energy level up at the base, everything gets better, right? The whole ship rises up when the tide goes up. So what we like to see is giving NAD to patients because as we age, again, it goes down like growth hormone. Both of these things, testosterone, ipamorelin, and NAD, the bottom line is you lose them as you age. That's just how it is. NAD levels start to go down in your 20s, and they just keep going down about 10, 15% a decade again. So as you get older, your levels are just in the toilet. You're not seeing the NAD you were producing when you're younger. So again, fatigue is a big thing. When I'm using NAD, it is something for fatigue. And I love The big reason about the sub-Q versus in the min or even in R or even the oral is that it is the most effective of all these. The argument I constantly get is that there is no receptor on the cell for this stuff. Not that anyone here cares about the backstory, but we may not know how it works right now. I will tell you that, but a lot of people out there, if you ever tried NAD sub-Q, you will know it works. There is a giant rush. Typically, you get a little hot flash when it comes with it, and you get a rush of energy. Usually within 30 minutes, you feel like you're just super energized. So either it's the best placebo effect I've ever seen across hundreds and hundreds of thousands of patients, or it does something. And my argument is going to be that makes a change in our bodies again. So it's going to change cognitive function will improve. You'll see better immune system. You'll see improvements in inflammation with SIRT1 and SIRT3 activation. These are anti-inflammatory sirtuin genes. They're going to turn on anti-inflammatory pathways. You're going to see improvements in metabolic function. So you're going to see more fat loss. If you pair this with a GLP-1, metabolism will go up and you can see more weight loss. I've had patients get stuck with a GLP-1. I add an NAD, and next thing you know, they're just dropping weight again. So we're seeing some more fat oxidation with that. NAD is, again, it's cell energy, right? So the immune system gets better. Everything in the body is going to improve across the board. NAD will repair DNA. So your DNA is going to be repaired, which again is really good as you get older. Just having the sun come down on you is going to damage DNA. NAD can come back and repair this DNA that's getting damaged. This is just part of the aging process. And the NAD we're giving back is going to help bring back the body's ability to make enough energy to run all the different things we have. So just think of this as the last thing your body needs to make energy is NAD. And if you don't have enough, you just aren't going to function as well as you can. Yes, question, please, Joey.
You know what this question is,
Yes.
right?
No, I don't know. Let's find
I
out.
don't even know. This might have been my first question for you.
Yeah.
This when we became friends,
Is
I think.
methylation?
Yes. Yeah.
Okay.
So I have a double MTHFR gene
Yeah.
mutation, and I think a lot of the population does. So
Yeah.
I was really bummed because I was taking, and this is just being completely transparent, because I saw some question, like somebody had a question, like, what if it doesn't work?
Yeah.
It didn't work for me. I had the complete reverse effect of it, which is
Yeah.
making me very sad because I
Yeah.
really do want it. So he still needs to figure out a plan for me because I'm on bio. You still have to figure out something for me.
I will. I will.
My question is like, so is it just sub Q for people that, have that double MTHFR? And so basically, guys, what's happening is you're not methylating. You're
Correct.
not pushing out the toxins, the free radicals. Am I correct in saying
Correct.
that?
Correct. Yep. Yep.
So for the normal person, you're able to filter that and keep all the good. But for me, I'm not. So what was happening to me was fatigue. I mean, I was so tired. I didn't want to get out of my bed. And then I saw his reel and he said, if you have this, sorry, basically.
Perfect. Have you tried since you've been on the B complex? Have you tried NAD since then?
No.
Okay. Well, I'm just curious. I would actually be curious to see how you handle NAD and if you have some at home now that you're on the
Is that the homeocysteine supreme?
Yeah, if you're on that, I'd be interested. Now, should you not take, so someone say, should you not take if you have an NTHFR gene mutation? Here's the thing. Let me kind of go back to genes. Genes are either turned on or off. So you can have a single mutation or double mutation, but that doesn't mean you're expressing it. You're only going to be expressing it if it's actively been turned on. So this is epigenetics. We have genetics, which is what's the code of our body, and epigenetics, what is turned on at this given moment. And if your epigenetic does not have the MTHFR turned on, you might be fine with methylation. How do I look at that? Big one's homocysteine for me. If I see high homocysteine, I'm almost positive this person has MTHFR genes. So I don't measure MTHFR genes in patients because I'm looking at homocysteine, I'm looking at folic acid, I'm looking at B12, I'll look at histamine levels. So these things will tell me and indicate if they're high and something's off with them, there's an MTHFR gene mutation, which again, we talked about is going to affect serotonin levels, dopamine levels, detox pathways, inflammation levels. So we really want to keep the body's homocysteine and level low and MTHFR gene mutation to help that. We support it with B complex, methylated B12, methylated folic acid, typically trimethylglycine. These things improve it. I use homocysteine supreme in my practice. And if I have a patient that's having a reaction from NAD, I'm typically going to add this in because they probably have some kind of MTHFR gene mutation. But again, just because you have the mutation does not mean you are actually expressing. I have patients with high homocysteine levels and I'm giving them NAD and they're still handling just fine. So yeah, you're Joey, I'm sorry.
Why?
You just
Why
don't
did I
know.
win that
I,
lottery?
I don't know.
I might
But
try it again, though. I might try it again.
yeah, I would just do it. You try one injection, but I would say go low. Like I would always tell patients if they're we start patients anywhere between 20 milligrams and 30 milligrams, and then we dose up to 100 milligrams in my practice. So we're going a little bit lower and then moving people up depending on tolerance. The second thing you want to be careful about is so the MTHFR gene mutation or having that turned on is can be an issue. Again, it doesn't mean and exclude you from using NAD. You still could use it potentially. The other thing, and the reason people particularly feel that shortness of breath, which is everyone feels this, can't breathe, get flush, that is actually an immune reaction. So the immune reaction we're seeing from NAD is because NAD is found in the cell and it's found in the mitochondria. And if all of a sudden you have a bunch of NAD in outside the cell in just the blood, all of a sudden your body's like, oh God, something's wrong. We just lost a bunch of cells. They all just burst open. We need an immune response. So there is a very quick histamine reaction does happen with this. I can't say I've had people with mast cell issues having problems with NAD. I haven't seen that before, but again, it does cause potentially a quick mast cell, basically not mast cell, a histamine reaction, which then could lead to that shortness of breath. That's what most people are feeling is this little immune response. But
So
don't
would
let
you
it scare
suggest
you.
would you think, because I know somebody, it was one of the brand partners said, I had to go lay down after I did my injection. Is she injecting it probably too quickly?
Not too quickly, it might be too much, right? My thing is always go low, like go slower, go less. So I that's why I start at 20. I used to not do it. I give people 100 and my God, my staff yelled at me so much because people get so mad. I mean, they're not telling me what's going on. They're not yelling at me. They're yelling at my staff who get all the answers get fielded to them. So they would get these answers like you've got to tell people lower dose. You have to tell people they're going to feel shortness of breath. This is totally common. Yes, I sometimes if I inject too much, I gotta lay down. Can't breathe. Like, let me tell you this. When you can't breathe, you typically know it's really good NAD. It's like you know it's the good stuff. I've used multiple companies before and people don't feel that chest tightness or it's been sitting in the fridge. Usually NAD is the most degradable. So just everyone out there, it degrades pretty quickly. Typically at about the 3 to 6 month mark, you've lost about 20 to 30% of how much is in there. So again, if you don't feel that chest tightness and you've had it in the fridge for a while, that's part of the reason it's degraded. When you get good NAD, it's like the good stuff, it's real good, is when you have that chest tightness, which is when you feel awful. That's how I know my NAD is really good. So you must have a really great product out there. People are telling you that I
Yes,
down.
yes,
That's a
yes,
very strong product, and I got to say the pharmacy is doing a great job at that
yes,
one. Uh,
yes, absolutely. I agree. I agree. I was going to say something. I completely forget what it was.
hmm,
Um, Never mind. Never mind. It's okay. How about we take a couple of questions?
sure.
You should see. Are you seeing the comments going off? This is crazy. You
I mean,
guys.
I can. I don't. I'm going to get distracted.
I know. I know. I know. We
Heisman
can't
Prize
multitask
here.
here. Okay, I'm just going to go up here. It says, can it assist with Cushing's disease? I know. First of all, we're not going to give medical advice. We can give
I can tell you what I do with a
educated
patient.
answers.
What I do with a patient that has whatever condition you tell me.
Yes.
Sure.
Okay. So Cushing's disease, prior or post pituitary surgery?